Uh, we have the public comment first, right, Joseph, as I see before the introduction.
I'm just going to go ahead and start with the roll call first, Dr. Khan, if that's all right.
Yeah, right. That's right. So please have the roll call.
Thank you. Joseph Filippi for the record. So we're going to start with our voting commissioners today, just to make sure we have quorum. So when you hear your name, please let us know that you're here. Commissioner Jalen Behunin.
Here.
Thank you. Commissioner BioCurry Winchell.
Here.
Thank you. Commissioner Walter Davis.
Here.
Thank you. Commissioner Flocon.
Here.
Commissioner Marilyn Kirkpatrick.
Here.
Thank you. Commissioner Andrea Peterson.
Here.
Commissioner Bethany Sexton.
Here.
Thank you. New Commissioner Dr. Mark Glyman.
I'm here.
Thank you. We do have another new commissioner, Commissioner Adam Parath. He was unfortunately unable to attend today, so we'll mark him absent excused. And finally, Chairman Dr. Khan. Dr. Khan, are you still there?
Yep.
I see you, but I'm not hearing you, sir.
I think he's frozen.
It's just one of those mornings, everyone.
Joseph, this is Marilyn. Do you want me to go ahead and just call for the public comment and move that along at least?
That'd be great, Marilyn. As the vice chair, let's go ahead and do that.
Okay, we're going to go ahead and go to item number 2, and we'll call for the public comment. So if you could raise your hand and state and spell your name for the record, that would be helpful.
Thanks, Marilyn. So anyone who's wishing to provide public comment today, if you're joining by phone, the phone number to join is 775-321-6111. When prompted for the meeting ID, it is 569-876-641#. And then you can press *5 to raise your hand, or if you're joining by computer, just raise your hand through the Teams platform. Jean Garreau, you have your hand raised. Please go ahead. You have 3 minutes to give your public comment today.
Thank you so much. I'm Jeannie Giroux, G-E-R-O-W, with the Nevada Hospital Association. And I'd just like to introduce a short video that we did on the nursing shortage.
Thank you. Please go ahead.
Okay, can you all see that?
Yep.
Perfect. Nevada has a severe shortage of nurses. We rank 45th in the nation for RNs per capita. And we need more than 3,000 RNs and LPNs just to hit the national average. And average isn't enough. Unless we act, Nevada will continue to face problems. Projections show Nevada will remain in the top 5 states with the greatest shortage. Nevada's nursing shortage may be worse than many analysts suspect. During the pandemic, Nevada healthcare facilities hired thousands of traveling nurses from around the country because of our nursing shortage. These nurses obtained the standard 2-year Nevada nursing license, and they still maintain that license even though they're not practicing in the state. Today, about 40% of Nevada's licensed RNs have an out-of-state address. The situation with traveling nurses likely masks the true number of nurses our state needs. Nevada RNs and LPNs are paid well. The annual mean wage for RNs is more than $97,000 and $66,000 for LPNs. So why do we have a shortage? During the pandemic, the lack of an available workforce caused nurses to burn out. The number of nursing school graduates hasn't kept pace with Nevada's rapidly growing population, further increasing the nurse shortage in Nevada. Each year, too many qualified students are denied admission to Nevada nursing schools. Schools don't have enough slots to educate more nurses. Let's work together to ensure that all qualified students with an interest in nursing can pursue their dreams of becoming a nurse.
Oh,
Thank you for sharing that video. And
you.
thank you for keeping it under the 3 minutes. Appreciate that. Are there anyone else this morning who'd wish to provide public comment today? Please raise your hand through the Teams platform or press *5. All right, hearing or not seeing any hands raised. Vice Chair Kirkpatrick, I think we can go on to agenda item number 3, which is informational today and a quick introduction of our new commission member, Dr. Mark Glyman.
Okay, I'm going to go ahead and close that public hearing and then go on to item number 3. And I'll go ahead and let the new members introduce themselves and tell us a little bit about you and why you really wanted to serve on the Patient Protection Board.
Hi, I'm Dr. Mark Lyman. I'm sorry I couldn't get this Teams to work, but I guess technicalities are always an issue. So I'm trained as a medical doctor and a dentist, both licensed in the state. I trained in dental school at UCLA, and then I went to medical school at Harvard Medical School. I trained in a combined general surgery and maxillofacial and craniofacial surgery program at Massachusetts General Hospital and Boston Children's Hospital. I started out here in 1992 as a practice doing surgery, and since that time I've been taking care of most of the facial trauma, head and neck cancer, craniofacial deformities, and other facial issues here in town. I've served as chief of staff at one of the large hospitals and chief of surgery at a number of hospitals, and I'm currently chief of surgery at Southern Hills Hospital. I've spent a large percentage of my career doing sort of public policy and working to make sure that safety of patients is probably my primary concern at the hospital, where I think that my focus has been that the safety of the patients in a hospital setting and in an office setting under office anesthesia is my number one concern. And then I think that that is probably my priority, is making sure that patients are well taken care of for the same standards that they would get in any facility, and I think it should be fairly uniform. So I'm very grateful that the governor appointed me to this commission, and I will try my best to put the public's needs above anyone else's.
Well, thank you. We appreciate that, and welcome to the committee. One of the hardest working subcommittees, I think, that's out there. So,
Thank you so much.
Can you see and hear me now?
yep.
Yes,
Okay.
thank you for joining, Chair Con.
All right.
Hi, this is Commissioner Davis. Could you, for Dr. Mark, I believe his, could you spell the last name? Is it Kleiman? I think I heard, but could you spell the last name?
G-L-Y-M, Glyman, G as in George, L-Y-M-A-N.
So we
Okay,
are
thank
on
you.
the new commissioner thing.
Yes.
Okay, have we introduced Dr. Glyman yet?
Yeah,
Yeah.
Commissioner Kirkpatrick, how far did we get?
we actually just finished up and welcomed Dr. Glyman, so we're good.
Oh, okay. Perfect. Dr. Glyman, welcome to the commission. I would like to say a couple of words about Dr. Glyman. I've known him from the time he came to town, long time ago. As you see from his resume, UCLA to Harvard to Massachusetts General and back to the state of Nevada. So he's a huge asset, a super subspecialty. Most importantly, he's a huge patient advocate, under which assignment he's with us, pushing very hard for the patient's well-being, fighting it out with the insurances to cover the patient's services and procedures. So welcome, Dr. Glyman or Commissioner Glyman, and I hope we look forward to benefiting from your expertise. Thank
Thank
you.
you, Doctor. I appreciate you.
All right. We are on to the next one now. Correct?
Yes, Chair, I think we're moving on to agenda item number 4.
Yeah, for possible action, are we going to do this one or postpone according to DAG?
To be consistent, let's go ahead and postpone all action items due to the technical issues that we're having this morning.
Oh, okay, perfect. So the item number 5 is informational overview of Nevada's health industry and insurance market. We have Scott Kipper, the insurance commissioner here from the Nevada Division of Insurance. Welcome, Commissioner Kipper.
Good morning, and Chair Khan, Vice Chair Kirkpatrick, and members of the Commission. For the record, Scott Kipper, I'm the Insurance Commissioner. Very pleased to be in front of you today to provide this informational overview. I am joined by Adam Plain. Adam is our insurance regulatory liaison, who will be providing the presentation. We do have a slide deck for you to follow along with. And again, we're most excited to provide this overview, and we'll certainly stand for questions as we go or at the end of the presentation. So Adam, if you would provide an introduction, and I'll let you get started.
Thank you, Commissioner. As he mentioned, my name is Adam Plain. I'm the regulation liaison for the division. I do a lot of policy work, presentations, coordinate as the legislative session gets going. I did provide a slide deck. Joseph, I don't know if it's easier for me to present or if you want to present using the PDF deck that I sent over.
Adam, if you're comfortable sharing your screen, that works for me. If you need me to pull it up, happy to do so.
No, I should be able to. Okay. All right. So hopefully everyone can see the presentation.
So I think we're seeing the view where it shows your notes as well.
Okay, I just sent it to present. Presentation in Teams failed. If I go into present mode, does that change anything for you?
It doesn't, but let me go ahead and pull it up for you, Adam. Give me one moment.
That's okay. We don't have any notes in the slide deck, so there's nothing worrisome in there.
Joseph, while they're working on it, a quick question. We used to have these meetings on Zoom before. Is there a reason we switched? I don't recall having problems with.
Chair Khan, I believe all state of Nevada agencies have been directed to use Microsoft Teams for public meetings.
Okay. Need to get the Microsoft people to figure this out. Have we heard any other commissions, board meetings having any issues, or just for some reason us?
I believe it was just us this morning.
Okay.
This is Gabe. I will jump in and say it's just us this morning, but many other issues have happened. Obviously, we've all had these types of issues as a result of remote technology. I mean, I'm thankful for remote technology, but it does seem like, things tend to go wrong.
All right, Adam, I think I have the presentation up. Feel free to start whenever you're ready, sir.
Perfect. I appreciate it. So if we go on to the first slide, it talks briefly about the Nevada Division of Insurance, our mission and functions. Our mission statement is to protect Nevada consumers and ensure that insurance carriers remain solvent. We are primarily a consumer protection agency. Nevada's insurance industry is approximately $25 billion annually in the state of Nevada. And Title 57, Nevada's insurance code, encompasses 60 chapters in the Nevada revised statutes. That's the single largest title in all of the state statutes. The division regulates the full gamut of insurance products, property, casualty, life, health, and so on. The state of Nevada currently has just shy of 1,500 authorized licensed insurers in the state, and 140 of those are domestic, meaning that they are Nevada companies. The division regulates just shy of 250,000 active individual licensed producers. Of those, 25,000 approximately are residents to the state of Nevada. We also have 16,000 licensees in other lines of business, which means that our total regulated licensees are over 265,000 licensees. The division does approve rates and forms for most lines of business. Some lines, it's just forms. Some lines are unregulated, like surety. We do financial examinations of insurers to ensure solvency. We do market conduct examinations of insurers to ensure compliance with trade practices and other guidance. We have a full consumer support team based in our our Las Vegas office, with some consumer support staff in Northern Nevada, Carson City as well. They field thousands of calls a year, simple questions, directing to phone numbers to contact insurers or producers, fielding complaints, helping adjudicate complaints. And the regulated insurance industry does generate over $600 million annually in insurance premium taxes for our state's general fund. It's one of the major revenue sources in the state. I believe it's number 4 currently in terms of revenue generated. Going on to an overview of the healthcare market in Nevada. The next few slides I will not take credit for. I have cannibalized these from an excellent presentation that our former Chief Deputy Commissioner Todd Rich made to the Nevada Hospital Association. That slide deck is available if you would like it. It is extraordinarily comprehensive. It's something like 56 slides long, which is why I've only cannibalized a few slides. Contact me at the division and I can get that out to you. I believe Joseph may also have a copy in PDF form, but I would, bother me. Don't bother him. He's probably busy enough as it is. So going into the healthcare market, Nevada's health insurance industry is the single largest insurance segment in terms of direct written premiums in the state. It makes up about 40% of all premiums written in the state. The division's role in this is analysis, review, and approval of rates and forms for the regulated markets. We have a large responsibility under the Affordable Care Act to make sure that plan design meets both state and federal law, that rates are not inadequate, not excessive, and not unfairly discriminatory. We have to make sure that the overall marketplace is competitive and stable for consumers. And it's important to note that the insurance products that the division regulates in the healthcare industry account for 25 different chapters of our Nevada revised statutes. That is a very large spread, and it makes it difficult for the insurance industry to know the full breadth of what they must comply with. It makes it difficult for consumers to understand what their protections and rights and responsibilities are. It makes it difficult for providers to know how their interactions with insurers and consumers are regulated. So it's a very daunting task at times. Moving to the next slide, this is a breakdown of Nevada's insurance marketplace for health insurance based on 2023 results, and it kind of just gives simple pie chart illustrating the various markets, the self-funded market, in groups is by far the largest component of health insurance coverage in the state. Medicaid and the Children's Health Insurance Program is the second largest. Again, keeping in mind these are 2023 results. As the changes through the Medicaid unwinding process happens, anticipate that Medicaid slice of the pie to shrink, and it hopefully will get taken up in other sectors, although we may see an increase in the overall uninsured rate. Important to note that in the large group market, the fully insured segment there, the yellow slice, the division approves the forms used by insurers, but we do not approve rates in that market. Generally speaking, it is assumed that large employers, one, are sophisticated enough along with their licensed producers to look out in their own best interests, and two, have unique circumstances such that a uniform rating system would not adequately encompass their needs and their situations. Also worth noting that the division does not explicitly review provider networks or drug formularies. There are some requirements around networks and formularies, and if an insurance company does not meet those requirements, the division could take regulatory action, but it is not a review and a stamp of approval kind of situation like it is for other portions of a policy form. Moving on to the next slide. This is some more information about the breakdown. I apologize, the numbers here are slightly different than in the previous slide. And you can see the reason is because in the data source, we're sourcing a lot of this enrollment information from outside agencies and sources. And so we don't necessarily have updated information from like the Kaiser Family Foundation or the military health system. So we've tried to match things to the most recent data we have available. You can see that as of say 2021, Nevada's covered population is around 90% of our full census population. This slide is important because highlighting, moving on to the next slide, made just a quick adjustment here. You can see those three circled sections account for approximately 19% of Nevada's population. Those are the three market segments that are subject to some sort of regulation by the state through the Division of Insurance. If you look at other markets, like right below it, the group market, the self-funded market, 35% of Nevada's population is through the self-funded group market. They're not subject to state regulation. It's preempted by the Federal Employee Retirement and Income Security Act, or ERISA. Below that, the Medicaid CHIP market is another 21%. Medicaid is not regulated by the division, right? Medicaid has its own set of standards. Similarly, Medicare is regulated by the Federal Centers for Medicare and Medicaid Services, or CMS. So as we talk about the division's role in regulating the industry for health insurance, we have to keep in mind that we're talking about a very small slice of health insurance that affects Nevada's population. It is roughly 20% that is subject to Nevada's Division of Insurance oversight.
And Adam,
yes,
we have Commissioner Kirkpatrick, looks like you have your hand raised. Do you have a question for Adam?
I do, and along those lines, so my question is, though, even those small amount of group insurance contracts or the MCOs for the Medicaid portion of it, do you have the ability, do we monitor like when they change how they pay for things or when they require. I've run into a lot of issues lately where certain insurance companies have one on Medicaid, they're saying, oh, you have to go through all these pre-requests in order to get this, or they've changed like uh, how they bill the anesthesiologist, and I don't know that other states aren't doing that. So I'm trying to understand if we can rein them in so that we're consistent throughout the community. Do you have the ability to do that?
That is a great question. So the relationship between the state and our Medicaid managed care providers, from I think the Division of Insurance's viewpoint, or my viewpoint at least, is a little bit complicated. So the Medicaid managed care provider organizations, sorry, the MCOs, are generally speaking commercial insurance products. As managed care organizations, they are subject to Chapter 695G of the Nevada Revised Statutes. Now, Medicaid, the Division of Healthcare Financing and Policy, may impose different responsibilities and restrictions on those managed care organizations through their contracting process. In terms of procedures for reimbursement to providers, some of those nuances, generally speaking, those are not regulated by the division, regardless of whether it's a Medicaid managed care organization or a commercial insurer. Now, the state does have certain protections, like our prompt pay statute, where if a claim is submitted and is complete, the insurer is required to pay within a certain amount of time or incur interest. There are certain requirements for medical management techniques, prior authorizations, step therapies, but specific provisions between reimbursements between a provider and a managed care organization, probably not something that currently exists. Whether it's worth exploring or not is maybe a question outside my level.
So can I follow up, Joseph?
Yes, please.
So
Go ahead.
even outside of Medicaid, one of the biggest things we hear from both the patient and the private sector is, one, they want to be paid, but if insurance companies come in and arbitrarily change things, and it's a little bit of a curve, right, to get back on track. And if you're telling the patient that they can't get in because their insurance doesn't work this way or that way, it goes back to the complication. And if only 5 states kind of let people do that, do we at the state maybe need some legislation to, this is the whole issue with, as you started with, is I don't even use my insurance because I don't know how it works, quite frankly, and I'm pretty savvy, but I can't figure out. I thought the state was going to a direction of you could go anywhere that you wanted. This is why we expanded Medicaid, and then we went to the insurance, whatever we call it nowadays.
Exchange.
Exchange. So when people got insurance, that you weren't trying to figure out what doctor was on what or the whole thing. And it seems that where insurance companies are able to still do it the old-fashioned way, and we've not progressed, we've gone backwards. So I'm wondering, do we need legislation to give you the authority to do that, or is that a federal thing? Because I don't know that we're making headway with patients, access to care, and then the payment. Prompt pay sounds great until they change their methodology on how they cover it.
This is Dr. Khan. I'm back on audio only. Sorry to interrupt, but I'm on. I can hear everybody.
Thanks, Dr. Khan.
I know that's a loaded question, but in layman's terms, the question I get from constituents is very, and I know it's complicated, but it just seems that maybe we need to look at some legislation to put some standards in place. so that if you're going to make a changement to how you process or your methodology of what you cover, they should give the state 180 days so that we can get the education out to people. I'm just curious. I've only seen 5 states really allow it, and I don't know if it's a trend coming.
Sure, that's a great question, Commissioner, and you'll forgive me. I will hearken back to some times in 2013 where I appeared in front of you at the Assembly Commerce and Labor Committee and gave some non-answer answers, and say that it's probably not in a position where I can say that legislation should or should not be introduced. You know, I'm sure you're aware we've got a provider shortage in practically every zip code in the state. You know, getting in to see doctors in a reasonable amount of time has always been an issue, and I don't know that a particular bill or statute around some of those provisions that you discussed would affect that. You know, as a state employee myself, there was notice recently of a prominent Northern Nevada hospital that was exiting a particular public employees benefit program network due to payment issues. It's something that I think we all face. I don't know that I have a better answer for you than that. I think the state of Nevada has viewed certain issues as contractual issues between two private parties, in this case, an insurer and a provider, that the state has been reluctant to step into. And whether the state chooses to change that viewpoint and change our stance on how some of those relationships work is, again, probably inappropriate for me to opine on.
No, I appreciate that, but maybe it's time to study what that looks like and what the proper notification time can be so that both the provider can continue to see patients, the patient can get access, and then we can do the prompt pay. So, okay, thank you.
Certainly.
And this is Commissioner Dr. Bio-Curry-Winchell. I second that. I think this is an important conversation that we need to talk about because although things are kind of what happens and this is kind of standard, doesn't mean it's acceptable. And I think there's an opportunity to kind of uncouple what happens right now and see what we could do to make progress so we can really keep at the forefront access to care, patient care outside of all of the other realms that are currently causing or challenging and actually barriers to getting the care that people need.
This is Joseph Filippi for the record. Thank you both for those comments. We'll go ahead and note that the commission has an interest in that topic and see if we can have a future discussion on that topic. Mr. Plain, if you're willing, if you want to go ahead and continue your presentation.
Certainly. We can move on to the next slide. So the reason that I had brought some of this information about Nevada's market and the regulated health insurance market is the invitation for Commissioner Kipper and I to appear today to make this presentation really stemmed from a conversation that had occurred related to health benefit mandates within the state of Nevada. And I think it's important to put into context, what Nevada's regulated market looks like. So moving forward, this conversation really stemmed from and revolves around what are known as essential health benefits and the essential health benefit benchmark. So when the Affordable Care Act was passed back in 2010, it required every state to select a benchmark plan of defined benefits, or EHBs, in 10 different categories, and all applicable plans. So it's plans essentially regulated by the state must cover those EHBs. Now, there's some exceptions to that statement, but generally speaking, that is the case. A benefit that is considered an essential health benefit may not be subject to annual or lifetime limits. States could choose to change their benchmark plan selection and the resulting package of essential health benefits, but there are certain limitations. Originally, the EHB benchmark package had very tight guardrails from the Centers for Medicare and Medicaid Services. The states were given a list of essentially 10 plans, and we had to choose one of them. As time has gone on, some of those guidelines and guardrails have loosened. So beginning in plan year 2026, states are not required to necessarily choose from that menu of 10 plans provided by CMS anymore. States can elect to add or remove EHB benefits on a piecemeal basis. So if we decided that a particular benefit was something we wanted to add, we could insert that one specific benefit. But there are pretty strict actuarial standards related to what they call generosity and typicality, meaning that the benefit that is contemplated being added by a state, one, under the typicality standard, can't push the overall cost of the EHB package too high or too low compared to where it currently stands. And two, under the generosity standard, it still has to be within a certain margin of error or allowance of any of those 10 plans that CMS had given us the option of selecting originally. So those guidelines are pretty tight, and it doesn't, even though we have flexibility to add a benefit or take away a benefit piecemeal, we really don't have as much flexibility as it seems like we do. Now, beginning in plan year 2027, the generosity standard, or our requirement to be within a certain margin of one of the 10 existing options, no longer applies. So all the state has is a ceiling and a floor, and that's a much more manageable target for the state if we decide to add or remove benefits from the benchmark package on a piecemeal basis. If you want to move on, Joseph. Oh, we have a question. So we'll take a question before we move on.
This is Commissioner Andrea Peterson. Just a question. So that does apply to fee-for-service Medicaid. Would that be true, those benchmarks?
Someone from Division of Healthcare Financing and Policy could correct me if I'm wrong, but I do not believe it applies to fee-for-service Medicaid. It would only apply to the regulated, fully insured market in Nevada, which is that approximately 20% that we showed in the prior slide. Now, there are arguments to be made that market pressures could force it to apply in the ERISA marketplace, the Taft-Hartley marketplace, the Medicaid fee-for-service marketplace, but whether those conditions actually occur or not is up for debate.
Thank you.
Certainly. So the next slide talks about advance payments of the premium tax credit. Again, another Affordable Care Act provision, to make insurance more affordable. It included a clause that if you purchase your coverage through an exchange and you are otherwise a qualified individual, you get a tax credit on your annual IRS tax return. Or in lieu of that, you can get it paid in advance to your health insurer to offset the immediate cost of your monthly premiums. The APTC, as it's known, is based on your projected income, and the cost of the second lowest price silver plan in your geographic rating area. And it's a key to note that because that second lowest silver plan is a factor in the premium advance payment of the premium tax calculation, when premium costs increase for whatever reason, it increases the value of the APTC to consumers, and thus it increases costs to the federal government through these APTC outlays. So if we want to go into the next slide, bringing it all together, why does this matter? Why are we making this presentation today? And this has to do with the issue of federal defrayal. Envisioning that states might take advantage of the APTC formula and pass a whole new slew of state mandated benefits, essentially saying, well, if APTC mechanism ensures that someone at 150% of the federal poverty level is never going to pay more than, say, $20 a month in their premiums, we can mandate a bunch of benefits and the costs will be borne by the federal government because our consumers will never still pay more than $20. So to prevent that, the Affordable Care Act locked the benefits that the government will pay for to those that are, one, in existence before 12/31/2011, and two, part of the state's essential health benefits package. Any state mandated benefits which do not meet those two requirements are considered additional required benefits under federal law. Under that same federal law, a state that is requiring a qualified health plan, meaning a plan essentially certified by the exchange, to offer benefits in addition to the essential health benefits, must make payments to defray the cost of any additional benefits. So that's the federal government's trap or out to prevent states from mandating a bunch of benefits under the assumption that it won't be a cost to consumers and the federal government will pay for it through the APTC mechanism. Go ahead and move on. So here on this slide, I've just kind of copied the pertinent federal regulation regarding defrayal and additional required benefits. We don't have to linger here. We can move on to the next one. But as you refer, back as you look at this on your own, it's important to note that the state's primary responsibility under defrayal are to identify which benefits in the fully insured regulated marketplace are, one, state required, and two, in addition to the EHB package. Once a state has identified mandates subject to defrayal, it is up to the QHP issuers, the insurance industry, to calculate the financial impact of those mandates. If there is a financial impact, the state must defray the cost and make payments either directly to the enrollee or to the QHP issuer on behalf of the enrollee. Now, the implication of this statement is that this is a premium side calculation, right? If the cost of additional required benefits, it implies that if a premium goes up by, say, $5 per month because of a required mandate, that's the cost. And you can conceivably pay that directly to the enrollee. But it's important to note that the federal government, CMS, has been permitting states to use a claims incurred calculation because it is our understanding that no state that currently pays defrayal actually makes the payment to the enrollees. Every state has, for I think logistical reasons, opted to pay the QHP issuers on behalf of an enrollee. So they use the claims incurred basis instead. We'll real quick go back, Joseph. The regulation in question at the federal level uses the terms QHP, QHP issuer, and an enrollee as defined in section 155.20. And that enrollee is defined to mean a qualified individual enrolled in a qualified health plan. That's important to note because someone who is not receiving advance payments of the premium tax credit, but is enrolled in a QHP, say they're above 400% of the federal poverty level, but they've still enrolled in a QHP through the exchange, or they elect to enroll in a QHP off the exchange because QHPs have to be sold at the same price both on and off the exchange, they still trigger defrayal for the state, even though there is no federal outlay. We have a question, so I'd be happy to take that.
Yes. So thank you. This is Flo Khan for the record. Okay, so I'm just trying to understand all that. So I just want to make sure. So any additional benefit is basically a responsibility of the state. And then if those additional benefits result in a premium increase, then an enrollee should either receive the money or the payer, the health plan payer, would receive the money to keep premiums down. Is that correct?
Yes, the general
From the state.
Correct. So as a maybe more specific kind of hypothetical example, if the state in the upcoming 2025 legislative session mandates that rhinoplasty must be a covered benefit, and that rhinoplasty causes premiums to rise by $20 per person per month, the state would identify that as a mandate in excess of EHB because it's not part of our essential health benefits package. And then the QHP issuers would do their actuarial calculations and say, that's going to raise premiums by $20 per person per month. And the state would be liable to either pay the consumers $20 per person per month or make a payment directly to the insurers of $20 per person per month to offset the cost.
Right. So how do we know as a consumer, how do you know that that $20 that's going to the payer, because as you just said, most states are choosing to send it to the payer as opposed to the enrollee, which makes perfect sense. But how do you know that that's actually going to keep the premium down by that $20?
It's a great question. So that is something that we at the division have had extensive conversations with our friends over at CMS over the last 12 months. Through the rate review and approval process each year when the insurers develop their plans and submit them to the division for approval, there is a specific process by which they have to identify or account for those benefits that the state has identified as being subject to defrayal and exclude them from their rate filing. Such that the premium that is filed with the state for approval and that is displayed to consumers either through the exchange or on the insurer's own webpage does not account for the impact of that benefit.
Okay.
So to use my hypothetical rhinoplasty example, someone who in 2024, without the rhinoplasty mandate, had a premium of $200 per person per month, would, assuming no other changes, no medical inflation or anything, with the existence of the rhinoplasty mandate, the insurer would still file the rate for approval with the division at $200 per person per month. The consumer would be charged $200 per person per month, and it would be left to the state and the insurer to reconcile that $20 rhinoplasty cost on their own.
Okay. And then you said the insurer is responsible for making the calculation of what that additional benefit would mean to premium, correct?
Correct.
Okay.
Yeah. And the state does have input and oversight of that through the rate review process. And the federal government does require that that calculation from the insurer be made by a member of the appropriate actuarial academy and conform to actuarial standards and practices and whatnot. So there is some reasonable reliance upon the accuracy of that calculation.
Okay. Thank you.
So moving on, kind of along those same lines, when it comes time to actually pay mandates under subject to defrayal, our friends at CMS have not given us a whole lot of information on how that should actually work. We've already discussed that there's an implication that the federal rule requires payment to be made on a premium rate basis. We're offsetting the cost. Conceivably, it could be paid directly to the consumer, right? That kind of implies that premium rate basis. Premium rate basis does offer states per member per month certainty. If we know, for example, rhinoplasty, the calculated amount is $20 per member per month, our only variable is the number of enrollees in qualified health plans, because the rest of it is an actuarial calculation certainty. Interestingly enough, to our knowledge, there aren't any states that actually use the premium rate basis for payment. Every state that we know of currently uses a claims incurred basis. And I think that first bullet point under the claims incurred basis is probably why. Because for logistical reasons, it doesn't make a whole lot of sense to mail checks directly to consumers. States have elected to pay the insurance carriers directly. A claims incurred basis, wherein an insurer may say, rather than $20 per member per month times our enrollment, we'll just give you all of our claims information. And you can determine what claims we paid were related to this, for example, rhinoplasty mandate, and the state reimburses them for those claims costs. That is a very clear audit and fiscal accountability trail, right? There is less susceptibility to unjust enrichment. If that $20 rhinoplasty cost is based on some actuarial assumptions that don't materialize, an insurer could conceivably profit from that defrayal. On the downside, that really removes incentives for insurers to control costs. If they know that 100% of the claims costs related to that mandate are going to be reimbursed, that could be viewed as an open checkbook. So that's really a give and take between the premium rate basis and the claims incurred basis. And then finally, the federal rule obligates the state to make payments. But something that many states have grappled with is, which state agency? Is this a general fund obligation? Is this a Silver State Health Insurance Exchange obligation? Is this a Division of Insurance obligation? How is it appropriated? If we go into Senate Finance hearing or Assembly Ways and Means hearing or go to Interim Finance Committee, like how is this mechanism actually going to work? And at this point, I don't know that any of those answers have been decided yet.
Commissioner Khan.
Yes, sorry, FloCon again. So I understand the claims incurred basis. One question I have is for like the drug benefit. So oftentimes you will get a claim for the wholesale price of that drug. And so you are paying what appears like a very high cost. But on the back end, those insurer payers are getting a significant, or could be getting a significant rebate on those drugs. How is that incorporated into the claim incurred basis to ensure that they're actually just getting paid for what they are actually paying for that product, given that rebate? How does that work?
That is a great question. Unfortunately, I don't have an answer. As it currently stands to the division's knowledge, every state besides Nevada, which may potentially be subject to defrayal, is subject to defrayal on a medical benefit. Nevada's conversations with CMS about whether or not we are subject to defrayal have to do with a pharmaceutical benefit. And we are the only state in the nation that have had these conversations. And thus we're kind of blazing a new trail.
Commissioner Kirkpatrick, did you have a question?
I do, thank you. So I'm glad that you brought that up, because we hear about those rebates a lot of times and they never actually go back to providing the health care and lowering the insurance costs. So I know particular, and I like to use the Teachers Health Fund Trust because they were getting those rebates, but yet the employees were seeing their costs rising. So it actually didn't go back into the cost of it. So when you have a 340B program, that typically goes back into the general fund. It's no different at the health district, right? But we've at least tried to put ours back into the pharmacy cost so that it keeps the pharmacy costs down as well, because the expenses are high. But is there, if we're the only, did I hear you say correctly that we're the only state that's really having that conversation? Is that a national conversation that we need to, I sit on a national board of counties, and there's 4,000 counties that sit on it. Happy to bring that topic up, because it seems that it should be required like we do with anything else, whether it's sewer, whether it's whatever, that it should have a nexus and go back into lowering the cost.
That's a good point. And to your question, I would say yes, to my knowledge, as it existed, say 60 days ago, no other state has a pharmaceutical benefit mandate. And so, on a medical mandate, like as with my rhinoplasty example, the claims adjudication process, the claims loss development process is, I think, a little bit more clear of a path to follow. There are some states that have had discussions with CMS on, I think, a more hypothetical basis about the pharmaceutical side. CMS has been very reluctant to share information definitively and in writing that we can rely on. So it is a new territory for us in figuring out how any potential payment scenario would work out. And I think we're open to suggestions without inviting a deluge of complaints. Right, this is something new that we're dealing with, that we don't profess to be the all-knowing experts on everything.
Thanks, Adam. Commissioner Sexton, did you have a question?
Just maybe a comment from the insurance perspective on the question about rebates. Certainly can't speak for every insurer and their methodology, but I would say that generally those rebates are taken into account when insurers are doing their actuarial analysis and working up to create the premiums. And so that, I'm not trying to speak to the federal defrayal payment or anything like that, but certainly those rebates would be built out in that cost analysis when those when the actuaries are actually looking at the data, not only just the claims payment, but also the rebates that might be accrued in terms of pharmacy costs. So just wanted to put that out there, that typically those are incorporated.
Commissioner Peterson?
Yeah, thanks. I'm just looking at some of my notes. So I'm trying to kind of relate this back to the all payer claims database, because I know that some states are, trying to use that to gain some transparency into payers. Do you know how that information is helping to project fiscal impact at all, or, anything on the all payer claims database related to this?
Yeah, again, really appreciate the question. That is very pertinent. When Nevada first started having conversations with CMS about potential theoretical defrayal situations, the all-payer claims database was not nearly at the point where it is today and where we hope it will be in the future. And we were having to do individual data calls to our licensed carriers, insurers, to get as much data as possible for our actuaries to review. The all payers claims database, will hopefully be a lifesaver in this regard for us, that we will have access to that data on a much more immediate basis. It will save division staff and contracted actuaries a tremendous amount of time and effort. It will save the industry a tremendous amount of administrative effort of having to comb through their claims runs and databases to get that information to us. I don't know that I can undersell or oversell. I don't know that I can misstate necessarily how important that will be for us once we get the full scope of some of these conversations known.
That's good to know. Thank you.
Great question, Ms. Peterson. And just so you all know, definitely, I think now that the all payer claims database is up and running and starting to have information submitted to it officially, hopefully within the next year, so we can have a formal, presentation and more discussion related to the information that's being submitted to that database in Nevada. Ms. Rubelin, did you have a comment regarding the database?
Yeah, I just wanted to provide the timeline. We do expect to have 3 years of historical data in July of this year. So it's currently in development, not currently fully, all the data is not quite there yet.
Thank you for that update. That's very helpful.
Sure.
Commissioner Kirkpatrick, do you have a question?
Thank you, Joseph. Actually, I just wanted to ask if maybe Bethany could reach out to me offline, because I want to understand how that actually goes back. Some of these, we're seeing, some of these drugs are $100,000 for one person a month. And so I'd love to have an offline conversation and not take up the commission's time on this.
Anybody else? I have a question. Is there anybody, the commissioner wants to ask a question before I do? No? So my question is a little bit different from, does the commissioner's office have data available on the insurer's denial of services statistically over a given period of time, year, 6 months, and denial of services to the patient after it's requested and supported by information from the provider? What is that percentage, and how many cases are denied at level 1, and then they go to the appeal and appeal? The challenge we see is the percentage, as I understand, is higher of denial to begin with at level 1, and then the insurance company would say, you have the right to go to appeal. Well, that takes another X number of weeks or whatever it does. And more often than not, the patient is exhausted. They are sick, the families have their own challenges, and then they are asked to fight an appeal with the help of information of the doctor. The doctors are busy, they are exhausted and tired, and they spend an inordinate amount of time trying to give more supportive evidence and more evidence. And in the final appeal, invariably, it is still the denial is upheld. What kind of data we have on these denials, and who audits this?
That's another good question. I do know that the state of Nevada participates in the National Association of Insurance Commissioners program for the Market Conduct Annual Statement. It's a filing that is done every year by not only our health insurance, but also, excuse me, our property and casualty insurance industry through our national group. There are some questions on that market conduct annual statement related to denial rates for claims. Typically, it's done by market segment, individual, small group, large group, catastrophic, and so on. Metal tier for the plan for on and off exchange products, amount of time required for the adjudication to be made initially. I think status of any follow-ups, was it appealed? If so, was it denied or upheld on appeal? There's a fairly robust amount of data related to claims denials in that market conduct annual statement. I apologize, I do not know off the top of my head whether the National Association of Insurance Commissioners makes that reported data publicly available or not.
Do we in Nevada have anything like that as the state of Nevada specifically? And if not, is there a reason not to have it?
So the state does not have our own reporting. We, as the Division of Insurance, have access to the results that our admitted insurers file with the National Association. So to provide it or to require it at the state level would just be duplicative of the filing that's already done, since we have access to it.
Well, I would like to have. I would like to see some. Go ahead, Dr. Glyman.
Just a point of order is who actually knows that data is correct? Because if the insurance companies are self-reporting denial of services, do we actually understand where that data is coming from? And maybe a state agency should be looking at the level of denials. I can just tell you from my own examples, and I won't bore the committee with this, is that you cite the rhinoplasty issue, which I actually do on kids with birth defects, and I do get paid the $20 for that procedure. I'm just joking, but pretty close. But with that said, you know, I've had multiple times where I have kids with cleft lip palate deformities that are denied because it's told that it's cosmetic surgery, and then we go through the second or third level of appeal, and then I have to do a dog and pony show where I have to go spend my evenings going in front of insurance companies to show that this kid needs this surgery done for appropriate reasons. And I'm not sure that we're actually capturing that data. So I'm just wondering, is that data available, and how do we know that data is correct?
Yeah, I reinforce. Go ahead.
Go ahead, Mr. Plain.
Oh, I was gonna say, I appreciate the comment. Like I said, I don't know offhand whether the data collected by the NAIC is publicly available. I will say, you know, having worked as a regulator, having worked in the industry, having done several different jobs throughout my 20-year career, you know, as the data is submitted to the NAIC, there are some very basic arithmetic checks that occur on the data to make sure that it is not abnormal. But beyond that, you know, when insurers have their financials audited and filed with you know, their regulators annually, their independent auditors do claims run checks, and that may include denials. The individual state regulators, the divisions, departments of insurance, you know, commerce agencies and whatnot, do examinations on the insurers, typically no less frequently than every 3 years. That can include claims runs, denial rates. When we get information substantiated that there may be an unfair trade practice or an unfair market conduct result occurring, the regulators can do targeted exams on a specific like claims practice or market practice to ensure that nothing is violating those particular laws. So there are some checks and oversight on those items.
But does that capture the amount of denials that are done on the initial basis when a provider tries to see if a surgery or a procedure or some other medical treatment is needed, or a drug prescribed for a patient which may be expensive but is a necessity for somebody? I mean, are we capturing that data?
I apologize. I do not know the answer to that offhand. That is something we can follow up with, though.
Okay, thank you.
Yeah.
Thanks, Mr. Plain. Commissioner Peterson, you have your hand raised.
I was just going to ask, can you comment on the recent parity that was done and, maybe some of the efforts that are taking place to bring insurers into compliance based on that analysis?
I'm sorry, I missed which analysis you were talking about. My microphone.
A parity analysis of insurers.
You're talking about the Mental Health Parity and Addiction Equity Act, I believe.
Yes. Yes.
I unfortunately do not have a lot of firsthand knowledge of that, so I cannot comment on that directly. I don't know if Commissioner is still available and can make a comment.
Yeah, your microphone did cut out, Commissioner Peterson, a little bit. Could you?
Oh, sorry. Yes, I am talking
there
about
we
the
go.
Mental Health Parity, and Addiction Equity Act that recently was conducted, and maybe some of the things that or efforts that are being taken to bring insurers into compliance based on that.
Sure, I'll be glad to touch that and handle that question. The division has been given a CMS grant to study several parts of our marketplace, including MAPIA compliance. We surveyed our carriers, and what we received back, this was last year, was an indication that the division needs to do a deeper dive. But in general, the material that we received indicate that there are some challenges in the marketplace. So we are performing an additional set of exams to drill down into this area specifically.
This is Dr. Khan. So what I would like to see is at our next meeting, if the Commissioner's office could bring back some specific data related to Nevada. We were told earlier that there's a national entity that does this now, and they probably do not release it. I would like to know why. And if they don't release it, why can't we release it? Number two, after this tragic incident not too long ago, some of the data specific to certain carriers of insurance was published. What was the percentage of denials? It varied from companies. Some companies were shown to have an increase in denials. They obviously received that data. New York Times had it. Wall Street Journal had it. So I really think we need to focus on Nevada, and I would like to see some specific data, because from my experience, every single day, various insurance companies deny transfer of patients to rehab facilities or long-term acute care facilities, and on and on and on. And patients sit in a hospital. It's not the safest place for them to sit for another 4 days when they don't belong here. This is the routine. I mean, everybody knows in the hospital system, case management, that insurance, they will never approve rehab, so don't even try. Well, how can you say they will never approve without any data? But that happens to be true. I really need this taken very seriously in the Commissioner's office with the report at our next meeting, very specific. What are the barriers for transparency? If you have to take it to the governor's office, we would like to do that, but we must have some transparency in this information. People would want to know what are they paying the premium and what are they getting in return. So kindly, if you would do some homework with some specific information, what is happening and what can be done as the state of Nevada Commissioner's office.
And if I can ask, based on that Parity Act, if we can maybe have some additional information regarding the steps that are being done. I know you said there's, some additional analysis being done, but what steps are being done based on the information that was found there to bring them into compliance?
Certainly.
Would be
Can I make,
helpful.
There
can I
were
make
some
one more
challenge-
point?
So what are those challenges? I would like to know that too.
Thank you.
I've just
Well,
one more
sorry,
point.
Dr. Glyman, Flo Khan had her hand raised. Let her go, and then we'll go to you, Dr. Glyman, please.
Thank you. So for the Commissioner's Office, thank you so much for the presentation today. It's super helpful, and I think it sparked a lot of discussion amongst the commissioners on things we need to look at. I had a question for the Insurance Commissioner. What are your priorities for 2025 that your office will be in the healthcare space?
Well, in the healthcare space, we have been working, and I think it'll be a priority for us in this year, is to work with the state Medicaid office in the development of the battle-born state plans, which is the public option and the reinsurance program that Governor Lombardo has directed us to work on. This has a go-live date of 1/1/26. So we've got a lot of work to do with our carriers, with our consultants, and certainly with our partners over at Medicaid. So I think on the health side, that will be our primary focus for the upcoming year.
And just as a follow-on, I know you've spoken or your office has been engaged on, cost and insurer practices and all of that. I think now you are also looking or have some authority to look at pharmacy benefit managers. Are you looking at the new FTC report that was released, or it was the second report that was released? Discussing like practices, particularly around prescription drugs and kind of the inflated cost, specifically around specialty generics?
There's a number of issues swirling around the pharmaceutical world and the regulation of pharmaceutical benefit managers, not only at the state level, but I know our colleagues across the country are working on this as a primary issue for 2025. So yes, we will be looking at that. We have all the material, and just as for the commission's edification, the PBMs are required to register with us as a third-party administrator, and therefore they're under the regulation of the agency as we regulate those TPAs.
This is Joseph Filippi. Just wanted to say thank you to Commissioner Kipper and Mr. Plain for the presentation, and I'm taking a lot of notes from this conversation about possible future agenda items. So this has been very helpful to me. And I know that you both will be relatively busy in the upcoming legislative session. So I will be in conversation with you between now and our next meeting, which is currently scheduled for March 14th. And we'll see about if we'll have an information to share by that point, or perhaps a later meeting date.
Yeah,
I have one comment when you get a chance.
Sorry, Dr. Glyman, please go ahead.
Yeah, I just wanted to dovetail with Dr. Khan's comment. I think that one of the issues that is not captured, and I'm not against companies making money or profit, but one of the issues is that if insurance companies deny all of the surgeries and then after review pay for half of them, they save half of their money. One of the hidden ways that we found in our office, just like Dr. Khan in trying to get people transferred or get people out of the hospitals, is that the insurance companies will only have access to get surgery scheduled or get patients taken care of from an office setting with one phone number. It's not even done online. in a number of cases, and that phone number either goes to hold forever, or you can never get a hold of somebody, or they do these auto hang-ups on you. So what happens is a number of offices just who are not persistent or don't really have the ability to take care of patients' needs will just give up, and then these patients are denied care or don't get the care that they deserve. So, and then what happens on the other end is the consumer is given a different phone number, and then they call up and say, well, why hasn't my surgery been scheduled? Well, we haven't heard from your doctor's office. Well, the reason you haven't heard from the doctor's office is nobody can get through to the insurance company to get these things scheduled. So it's sort of one of these hidden ways that the care is sort of delayed or denied. And I think that I'm wondering if at some point whether we can look at that level and have some uniformity in terms of these insurance companies, not Medicaid or Medicare, in terms of having some legislation or language just so that the providers can have the ability to contact these companies in a fair way and not be cut off or not have the inability to get through to them. So that's my comment. Thank you.
Anyone else, any comment or questions before we go to the next item? Joseph, do you see anybody's hand up?
No, I do not, Dr. Khan.
Okay, this was a very robust discussion, and certainly we would look forward to some response from our commissioner's office next week to some lot of good questions raised. We are next on another item number, is it 5 is where we were. And then
yes, Dr. Khan, I think, yep, we're on item number 6, which is an informational item.
Yep.
So today we have Melinda Southard from the Division of Healthcare Financing and Policy. Melinda, do you want me to pull up the slides, or are you happy to share?
Oh, thanks, Joseph. I can go ahead and share my slides.
Perfect.
Sure.
So the agenda item today is an overview of Assembly Bill 7 from the 2023 session and the implementation update regarding the approved regulations associated.
Great, thank you. Good morning, Patient Protection Commission and commissioners. My name is Melinda Southard, and I serve as a Deputy Administrator with the Division of Healthcare Financing and Policy. Thank you all so much for inviting me here today to provide this update for you. So going into our agenda, I wanted to give a quick overview of Assembly Bill 7, and then go into the regulations development process, and then provide you with some updates on some implementation activities. So the Commission initially proposed what became Assembly Bill 7 in the 2023 legislature as one of the Commission's BDRs. The Commission felt it was important for healthcare providers in our state to work off an electronic healthcare record system that was interoperable with other electronic healthcare record systems. So the Commission also wanted patients to have direct access to their records electronically, with the ability to receive and forward their medical records electronically to others of their choosing. After the 2023 legislature passed Assembly Bill 7, the Department of Health and Human Services delegated implementation to the Division of Healthcare Financing and Policy, and we had some work to do. So the bill required the director to adopt regulations governing health information exchanges and the transmittal, ownership, management, use, and confidentiality of electronic health records. These regulations also had certain criteria that were required to be included, such as prescribing a framework for the electronic maintenance, transmittal, and exchange of electronic health records, prescriptions, and health-related information. Also requiring the ability for patients to directly access and forward their medical records electronically, and requiring the interoperability of these networks and technologies. Lastly, surrounding the development of these regulations, the bill required the director to convene an advisory group to advise him in the adoption of such standards. So early in 2024, the director assembled the Electronic Health Information Advisory Group, and that's pursuant to the bill text that you see here on this slide. The bill itself required the department to recruit at least one member from each of the 10 categories of members that you see here, to help make up this important advisory committee. I also included a link here which references the complete list of the 20 appointed members plus the 9 ex officio members of this advisory group. The advisory group initially met on March 7th for group orientation and information regarding the responsibilities of the group. April 4th was the first meeting where the group was presented with some draft regulatory language where we received some constructive feedback. And then again, at the May 2nd meeting, the group was presented with some more draft regulatory language, taking into account, of course, all the feedback from the first draft. So then at the June 17th meeting, the group reviewed the third draft. The members really held a robust and thoughtful discussion on many of the aspects of the drafted language, and they ultimately voted to approve the draft regulation language to be put forward in advisement of the director in the adoption of the regulations. Throughout the regulatory language development process, the advisory group held on to 3 main points that the regulations had to address. So first, the regulations had to provide flexible options for providers of healthcare. The advisory group really felt it important that providers not be held to a single solution for compliance, but rather that there be 2 options providers could choose from. So they could either implement a compliant electronic health record system, or they could implement a compliant health information exchange. Secondly, the regulations had to require that both compliant solutions allow patients to directly access their health records electronically and provide the ability for patients to forward those records electronically to others. Lastly, the regulations had to be in alignment with federal best practices surrounding interoperability. So this meant for the electronic health records, they had to be compliant. In order to be compliant with state law, they must be certified by the Office of the National Coordinator for Health Information Technology of the United States Department of Health and Human Services. And in order for the health information exchanges to be compliant with state law, they must be a member of the Trusted Exchange Framework and Common Agreement, which is otherwise known as TEFCA. And I included links here if you would like to see some more information on either of those. Now, before the draft regulatory language that was developed and approved by the advisory group was submitted to the Legislative Council Bureau, that's the next step in the process, the department chose to add some clarifying language, and the department included language that stated that no provider of healthcare is required to use a health information exchange. So this also upheld the initial requirements of the bill, and it did not bind providers to any one solution. So you may be wondering what happens next. So let's go ahead and walk through those details. So first, the draft regulations were approved by the director on June 26th. They were then submitted to the Legislative Council Bureau on June 27th, which, by the way, was just a few days before the deadline of June 30th. So very happy we made that deadline. LCB completed their review of the regulations and sent their version back to the department on August 28th. So this is when the regulations were assigned that R number, or LCB file number R173-24. So this is assigned to help track the regulations the rest of the way through the official administrative rulemaking process. The state held a public workshop to gather public comment and input on the proposed regulations on September 4th, and the required public hearing to gather further public comment and input was held on October 31st. Finally, at the last meeting of the Legislative Commission in 2024, the regulations were approved and filed with the Secretary of State on December 19th. So now that we have some approved regulations, we'll go through some more implementation updates. So the approved regulations were effective upon approval of the Legislative Commission. So this means that they are currently in effect. This means that all healthcare providers and medical facilities licensed to operate in Nevada must be able to maintain, transmit, and exchange health information in accordance with the new state law. As documented in the enrolled bill text, all hospitals and physician group practices with more than 20 employees must meet the requirements by July 1st, 2024. All other healthcare providers and entities, unless they're called out below, must comply by July 1st, 2025. And physician group practices with 20 or fewer employees, solo practitioners, and small healthcare businesses must comply by January 1st of 2030. Another requirement from Assembly Bill 7 is for the department to implement a process for healthcare providers to apply for a waiver from the requirements of Nevada Revised Statute 439.589, provided that the healthcare provider does not have the infrastructure necessary to comply with those provisions, and obtaining such infrastructure is not reasonably practicable, including without limitation, because the cost of such infrastructure would make it difficult for the healthcare provider to continue to operate. So a public workshop was held on December 31st regarding the waiver process, where we received some really thoughtful public comment and feedback. So the department is currently considering this feedback in the development of the waiver process, and we hope to have that published within the next few weeks. So all information related to this public workshop may be found under the archive section of our division's public notices webpage. And I've also provided a link to the advisory group webpage on this slide here. And that is the group webpage that will be updated with the approved regulation announcement, and where the department will maintain all information and notices related to Assembly Bill 7. So lastly, the Division of Healthcare Financing and Policy has been tasked with managing the appropriated funds to award grants to healthcare providers to comply with the requirements of NRS 439.589. So this one-time funding is available for eligible applicants to purchase and implement a system for the electronic maintenance, transmittal, and exchange of electronic health records, prescriptions, and health-related information in compliance with state law. The funding is only available through June 30th of this year, so all eligible applicants are really encouraged to apply as soon as possible due to those time and funding limitations. Eligible applicants for the grant funding are listed here, and we also provided a link to the notice of the grant funding opportunity, which goes over the rules, eligibility criteria, and the instructions for how to apply. And with that, I will stand for any questions. Thank you.
Thanks, Melinda. Appreciate that presentation. Are there any questions from commission members this morning? Hearing none. Okay. Thank you, Melinda. Just for awareness of all the commission, I invited Melinda, one, to give an overview of that bill, just because it was a result of a prior PPC piece of legislation. But additionally, which it is an action item, so unfortunately we can't vote on the item today, but the following item was to discuss the commission to recognize the implementation of the bill and the regulations presented as meeting requirements of statute that requires the commission to actually develop an annual plan to increase access and interoperability to health records. And so in reviewing that statute, it was created prior to this bill and the regulations that were recently established. So in reviewing that requirement of the PPC, for a future meeting, just wanted to ask the group if they were willing to consider the regulations in the bill as meeting the same intent, thus removing the requirement for us to develop a plan annually to increase access for these health records. So just a little bit of background on why that was on the agenda today and for a future discussion as well. All right, hearing no questions, Melinda, Commissioner Kirkpatrick, please go ahead.
Sorry, so Joseph, are you asking us to kind of give you some direction so that both sides can move forward, even though we're not taking a motion on it? We can still give you some direction, right? Whether or not it needs to come back or whether or not.
Sure, if you all are willing
to. I feel like
to.
you're asking us for something and we're giving you nothing. But
Well,
for me,
yeah, I appreciate that, Marilyn. If the commission is willing to discuss it today, and of course we can't make a decision or a motion, but we can, I guess, talk about your initial thoughts on that concept. That would be helpful, or we could just table this item for a future discussion as well.
well, for me personally, look, it takes long enough to get through the regulation process and all that. I don't know what a report's going to do except be duplicative. I do think we could administratively review to, have them come back in a year to how's it going. But I don't know about creating a plan because we have a full plate. They've obviously put in everything that they need, but at least so people are prepared to come back next time and make a quicker decision or discussion for me.
Thank you, Commissioner. I appreciate that feedback. And that was my initial thought as well. We just, understanding you all have full-time jobs and professions in addition to serving on this commission, one less thing that you all would have to do on an annual basis. And just realizing that the division and the department have already kind of, due to your prior bill, have met a similar intent of increasing access for patient medical records was the reason for that. So unfortunately, due to technical difficulties, we can't make a formal motion on that, but I'll plan to bring that forward at a future meeting. And hopefully it's a quick agenda item that we can discuss and vote on. So appreciate that feedback. Awesome. So due to us having to kind of work around the agenda today, we did have an item to discuss future meeting dates and topics. It's also a 4 action item, but so informally, just wanted to note that our next scheduled meeting is scheduled for Friday, March 14th, where I plan to hopefully give you all an update on where the PPC bills are in the legislative process at that point. And then I additionally plan to send an electronic survey to you all within the next week or so. Just with a few questions, nothing too lengthy, asking for some feedback and thoughts on future agenda items and areas that you would like to have the commission focus on throughout the next calendar year. So hoping to send that to you within the next week, as I mentioned, and then we can discuss some of the feedback from that survey and kind of develop an action plan or a plan for going forward for our next year or so. Is there any comments or questions regarding that? Perfect. Hearing none. Dr. Khan, if you're okay with it, we can go ahead and open up the last public comment period. Dr. Khan, you're muted if you want to press *6 to unmute. It's been one of those mornings, everyone. Apologies. Vice Chair Kirkpatrick, are you all right if we go ahead and open public comment?
Yes, this is the second time set aside for public comment. At this time, you can talk about anything that pertains to the PBC. So we'll go ahead and Joseph, if you have anybody wishing to have public comment.
If you'd like to provide public comment today, please press *5 to raise your hand if joining by phone, or raise your hand through the Teams platform. Seeing no requests for public comment, I think we can go ahead and move to the next item, which is for adjournment.
So I just got to close public comment. That's a thing. So
thanks, Marilyn.
Let me close public comment. Your dad probably loves me for that. So I'll go ahead and close public comment, and then I would entertain a motion to adjourn.
Motion.
Okay, I have a motion on the floor, and I have a second. Any discussion? We're adjourned. See you in February.
See you all in March. Thank you.
Thank you.
Thanks.